Welcome to the deep dive.
Yeah.
Imagine your body as this incredibly complex, finely tuned machine. And inside the bone marrow is like its vital factory working nonstop, producing all the essential parts of your blood. It's amazing, really.
Absolutely. A biological marvel. Trillions of cells constantly being made.
But what happens when that factory hits a major crisis?
Yeah.
Like a sudden, massive breakdown. Or maybe it just slowly starts to fail from the inside.
Yeah.
What are the implications when the source of our blood cells, falters?
That's the core question, isn't it? And the implications are, well, they're huge.
Yeah.
They affect every single system in the body. Understanding how we diagnose these issues, how we treat them, that's mastering some really intricate medicine.
Right.
And our goal today is to give you that kind of professional grade insight.
Absolutely. So today we're taking a deep dive into exactly that, the intricate, often really challenging world of bone marrow failure. We'll kick things off with the immediate shock, the acute blood loss scenario. That's acute post-haemorrhagic anemia.
The APHA, yeah.
And then we'll move into a really thorough exploration of the key bone marrow failure syndromes. We're talking aplastic anemia, pure red cell aplasia, myelodysplastic syndromes, or MDS.
And myelophysic anemias, too.
Right. Our mission, as always, is to unpack these complex conditions with the detail and understanding that professionals use, basically giving you a shortcut to mastering this crucial info.
And our guide for this exploration comes from deep dives into a highly respected medical text, Chapter 102 specifically, which covers these critical blood disorders in great depth. We've pulled out the most important insights, the key nuggets to make sure you get a really well-informed perspective.
Okay, let's start with that sudden crisis, that massive leak. Acute post-haemorrhagic anemia, APHA.
Right, APHA. This is an immediate, urgent crisis for the body. When you lose a lot of blood really quickly, the body doesn't just, sit there. It kicks off this incredibly sophisticated physiological cascade. Think of it like an internal emergency response team jumping into action.
Okay, so what does that response actually look like, physiologically speaking? How does the body try to cope when it's losing blood so fast? What are its priorities?
The number one priority is maintaining perfusion, keeping blood flowing to the vital organs, especially the brain and heart.
Makes sense.
So it immediately releases powerful hormones. Vasopressin is a key one, and other peptides. These act as potent vasoconstrictors.
Meaning they squeeze the blood vessels?
Exactly. They narrow the vessels, trying to reduce blood flow to less critical areas, contain the bleeding, and keep the blood pressure up. But here's the really clever part. The body also starts pulling fluid from outside the blood vessels, from the tissues.
Like the spaces between cells.
Precisely, the extravascular compartment. It pulls that fluid into the bloodstream, the intravascular compartment. It's basically trying to refill the tank, boost the circulating volume.
So it's kind of borrowing water from the tissues to keep the blood moving, even if that means diluting what's left?
You got it. And that fluid shift leads to something called hemodilution. Initially, the biggest, most immediate danger is hypovolemia, critically low blood volume, which can lead to shock.
Right.
But as this fluid shifts in and dilutes the remaining blood cells, that hypovolemia slowly, or maybe not so slowly, turns into a state of anemia. And the degree of anemia tells you directly how much blood was lost. I mean, the source material gives this really striking example.
Yeah.
If, after about 3 days, let's say, a patient's hemoglobin is down to 7 grams per deciliter, that indicates roughly half of their entire blood volume has been lost.
Half? Wow. That really puts the severity into perspective, makes the emergency response crystal clear.
Yeah.
So, okay, if the bleeding stops, does the bone marrow factory then just ramp up production to fix the anemia? Or is it slower?
Yeah, assuming the hemorrhage is stopped, the bone marrow does eventually respond to try and fix the anemia, but it's gradual, not instant. You'll see signs like an elevated reticulocyte count.
Those are the baby red blood cells, right?
Exactly. Immature red cells, seeing more of them means the marrow is actively trying to produce more. You'd also see higher levels of erythropoietin or EPO, that's the hormone from the kidneys, telling the marrow, make more red cells.
Oh, okay.
What's interesting is that this response, this ramp up in red cell production, it's quite similar to how the marrow responds to hemolysis, when red cells are being destroyed too quickly. The body's alarm system for low oxygen seems pretty consistent.
So the underlying mechanism is similar for different kinds of red cell loss. Okay, now diagnosing APHA. Sounds easy if someone's bleeding externally, obviously. But what about internal bleeding? That seems like a huge diagnostic challenge.
Oh, absolutely. Overt bleeding, you see it. Diagnosis is straightforward. But internal bleeding, maybe after trauma, it can be massive, but completely hidden. Someone takes a hit, no visible wounds, but they're bleeding internally. So the question becomes, what subtle signs do we look for? How do we find that hidden bleed?
Crucial question. So what are those signs? Those physical findings that can help pinpoint internal bleeding even when you can't see it. What clues does the body give us?
Well, the text points out some specific classic signs. For instance, Gray-Turner sign, that's bruising, ecchymosis on the flanks, that can point to retroperitoneal bleeding behind the abdominal lining.
Okay, like from a kidney injury.
Kidney, pancreas, yeah. Then there's Cullen sign, bruising around the umbilicus, the belly button. That could suggest bleeding inside the abdominal cavity, intraperitoneal, or also retroperitoneal. And if you suspect bleeding in the chest cavity, intrapleural bleeding, maybe from a lung injury, finding dullness when you percuss the chest can be a key sign of fluid buildup. Subtle but vital clues.
So the takeaway is, if a patient presents with a sudden, unexplained drop in hemoglobin, even if they don't report an injury, APHA has to be high on the differential diagnosis list.
Yeah.
Don't rule it out just because the bleed isn't obvious.
That is a critical, potentially life-saving directive. Any abrupt fall in hemoglobin warrants suspicion and investigation for APHA, no matter the initial story. It's a reminder that what's happening inside can be deceptive. You might need to dig deeper with questioning, looking for subtle symptoms, and definitely use imaging like sonograms or maybe endoscopy to find the source, check the abdomen, GI tract, anywhere it could be hiding.
And once you suspect or confirm that hidden bleed, what's the immediate game plan for treatment? Life-saving interventions first, I assume.
Absolutely paramount. If the patient is hemodynamically unstable, low blood pressure, racing heart, the standard ABCs come first. Airway, breathing, circulation. Ensure they can breathe, check the heart, support circulation. And if there's hypotension, low blood pressure linked to the bleeding, then pharmacologic support with vasopressors is critical.
Those drugs that raise blood pressure.
Right. They constrict vessels, stabilize the pressure, buy you precious time.
Now, treating the anemia itself. You mentioned it's different from how we approach chronic anemia. What's the key difference there?
It's a really pivotal distinction. In acute blood loss, you need a two-pronged approach, and it's basically the reverse of treating many chronic anemias. With chronic conditions, say iron deficiency, the body often adapts slowly to lower hemoglobin. So the first priority is finding and fixing the cause. You might not even need a transfusion.
Okay.
But in acute severe blood loss, the body has had zero time to adapt. So immediate blood transfusion takes priority. You need to replace that lost volume and oxygen carrying capacity right away.
Yeah.
Stabilize first.
You get the blood in fast.
Okay.
And the second prong of that emergency response.
While you're transfusing, dealing with the immediate crisis, you must simultaneously work to stop the hemorrhage itself, find the source and eliminate it. You're rescuing and fixing the root cause. And for volume expansion, replacing lost fluid, plasma is actually often preferred over just saline.
Why plasma specifically?
Because crystalloid solutions like saline can actually dilute the clotting factors the patient still has, potentially making the bleeding worse by interfering with hemostasis, the clotting process. Plasma, on the other hand, contains those clotting factors, so it helps support the body's own ability to stop the bleed while replacing volume.
That's a key detail. Plasma helping with clotting. Shows how nuanced these emergencies are. Are there special types of APHA to consider? Like, what about surgery?
Yes, definitely. Blood loss during and right after surgery is a specific and very common type of APHA. It can be significant. The text mentions up to 2 liters lost during a radical prostatectomy.
Wow.
For elective surgeries, some patients might do preoperative autologous donate their own blood beforehand to be used if needed. Avoids donor blood risks. And because surgical blood loss is iatrogenic, caused by the procedure itself, there's a huge responsibility to monitor it closely, measure it accurately, and manage it optimally. It's controlled, but still needs careful handling.
Moving beyond immediate management, what's been the sort of holy grail in emergency medicine for severe hemorrhage? Something that could really change the game.
Ah, yes. For a long time, the ultimate goal, the holy grail, has been a universally available, safe, easily stored and transported, and effective blood substitute. Think about disaster zones, battlefields, remote areas, places where blood banks aren't available or time is critical.
Right, something you could just grab and use.
Exactly, something that delivers oxygen without needing blood typing or cross-matching. It would revolutionize emergency care in those situations.
So what avenues have researchers explored to create this substitute?
Primarily 2 main paths. First, synthetic chemicals called fluorocarbons. These are designed to bind and release oxygen, mimicking hemoglobin. Second, artificially modified hemoglobins called hemoglobin-based oxygen carriers, or HBOCs. These are basically purified hemoglobin, often from animal or human sources, altered to be stable and less toxic outside red cells.
Have any of these gotten close?
Well, there have been anecdotal reports, and HBOCs have reached phase 2 and 3 clinical trials, meaning larger human studies. But, and this is the key point, no blood substitute has yet become standard treatment in routine clinical practice. There have been safety concerns, issues with side effects. The search for that perfect, safe, effective substitute is definitely still ongoing.
So, huge progress in managing acute blood loss. But the ideal substitute is still on the horizon. Okay, let's shift gears now. From that sudden massive factory leak, let's move to the more insidious problem, the bone marrow failure syndromes. If APHA is the leak, these are more like a fundamental breakdown of the factory's production line itself.
That's a really good analogy. Bone marrow failure diseases. This includes conditions like aplastic anemia, myelodysplastic syndrome, MDS, pure red cell aplasia, PRCA, and myelodysplasia. The common theme across all of them is that the low blood counts are happening because of deficient hematopoiesis. The marrow just isn't making enough cells.
Okay, so it's a production problem at the source.
Exactly. This is fundamentally different from conditions where blood counts are low because cells are being destroyed too quickly after they're made and released, like in hemolytic anemias where red cells break down, or ITP where platelets are destroyed, or immune leukopenias. In marrow failure, the factory itself is failing.
Got it. So, what are the key signs that tell us the factory production line is faltering? What do we typically see?
Well, hypoproliferative anemia, meaning not enough red cell production, is a cardinal feature, a really prominent sign. But often what we actually see is pancytopenia.
Which is low counts of everything.
Right. Anemia plus leukopenia, low white cells, especially neutrophils and thrombocytopenia, low platelets, all three lines are down. It's also worth remembering that marrow damage can sometimes be secondary, caused by things like chronic infections, widespread inflammation, or even cancer infiltrating the marrow.
Given these syndromes can present differently, how do doctors classify them? And is it always easy to tell them apart? Sounds complex.
They're generally classified by the dominant features seen in the bone marrow biopsy, the morphology. Usually the distinction is clear enough from the pathology report, but sometimes these processes are so closely related that diagnosis can be incredibly complex, even for hematologists.
Like distinguishing aplastic anemia from certain types of MDS.
Exactly. Distinguishing aplastic anemia from hypocellular MDS, where the marrow looks similarly empty, but the underlying problem is different. That can be particularly tough. And now, with modern genomic screening, we can find mutations. But are they truly causing the disease, or are they just risk factors? It adds another layer. Patients might even seem to have aspects of multiple related diseases at once, or one diagnosis might actually evolve into another over time. It reflects this dynamic interplay between cell dysfunction and genetic instability.
Wow, so it's a really dynamic, sometimes blurry picture, a real diagnostic puzzle. But despite the different presentations, do these conditions share any common underlying mechanisms? Is there a common thread in these factory breakdowns?
Yes, interestingly, many of them seem to share an immune-mediated mechanism. The body's own immune system might be mistakenly attacking the blood-producing factory.
An autoimmune attack on the marrow.
It seems that way in many cases. Plus, there's often an element of genomic instability. The cell's genetic material is prone to errors. This leads to a higher risk of malignant transformation, developing leukemia or other blood cancers down the line, so it's often a double whammy immune attack plus genetic instability.
And why is it so critical for even general practitioners, not just specialists, to recognize these syndromes early? What's the practical importance?
It's crucial because the quality of life and the ultimate prognosis can be quite poor if these conditions aren't caught and treated. The good news is effective therapies exist now, but they are often complex. Choosing the right one, managing it really requires care from a hematologist or oncologist. And genomic screening, which a GP might initiate if they suspect something's wrong, has truly revolutionized diagnosis. But interpreting those complex genetic results, that still needs expert input from the specialists to guide the next steps. It really highlights the need for teamwork.
So genomics is a powerful tool, but it's part of a bigger puzzle needing expert interpretation. Okay, let's drill down into one of the core syndromes, aplastic anemia. This sounds like the ultimate empty factory scenario.
Exactly. Aplastic anemia is fundamentally defined by that combination: pancytopenia, low counts of everything, and bone marrow hypocellularity. The marrow is basically empty, replaced by fat, instead of blood-producing cells.
Okay.
And it's important to distinguish acquired aplastic anemia, which develops over time, from other situations. For example, iatrogenic aplasia, that's marrow suppression caused intentionally by chemotherapy.
Right, where you expect it.
Or from accidental physical or chemical injury like severe radiation poisoning. Those are different scenarios.
Are there inherited forms too? Conditions people are born with that lead to this?
Yes, absolutely. Aplastic anemia can be constitutional, meaning it has a genetic basis. These include inherited diseases like Fanconi anemia and dyskeratosis congenita. These often, though not always, show up in childhood and might come with specific physical anomalies that are clues.
Okay.
We also see it with telomere diseases, problems with the protective caps on chromosomes, and sometimes with mutations in key blood development genes like GATA2 and RUNX1. Sometimes these inherited forms look identical to the acquired form in the marrow biopsy, which is why genomic testing becomes so critical.
What about the epidemiology?
Right.
Is aplastic anemia common? Who gets it? In geographical patterns?
It's considered rare. In Europe and Israel, the incidence is about 2 cases per million people per year. But interestingly, it's higher in places like Thailand and China, maybe 5 to 7 cases per million.
Suggesting maybe environmental factors or genetic differences?
Exactly. It affects men and women equally. But there's this biphasic age distribution, 2 peaks. One major peak in the teens and 20s, and then another rise in older adults. This suggests different causes or triggers might be more common at different ages.
So what are those causes? Unraveling the etiology sounds tough, especially since you said many cases are idiopathic, meaning cause unknown.
It is a major challenge. Most cases are idiopathic. And while we see certain clinical associations pop up repeatedly, it's hard to know in an individual patient if that association is the actual cause. Often there's very little separating an idiopathic case from one where we have a presumed cause other than the patient's history.
Let's talk about some of those presumed causes. Radiation seems like an obvious one for damaging marrow. How does that work?
It is obvious, yeah. Marrowplasia is a major immediate consequence of significant radiation exposure. Radiation directly damages DNA, and tissues that turn over rapidly, like bone marrow, where cells are constantly dividing, are super sensitive.
So nuclear accidents, occupational exposure.
Right. Power plant workers, people in hospitals or labs handling radioactive materials, even innocent people exposed accidentally. You can roughly estimate the dose by how quickly and how much the blood counts drop. But it's interesting, while MDS and leukemia are known late effects of radiation, developing years later, aplastic anemia itself probably isn't a typical late effect. It's more of an acute consequence.
What about chemicals? Benzene has a really bad reputation for marrow toxicity, right?
Absolutely notorious. There's strong data, epidemiologic, clinical, lab linking benzene exposure to aplastic anemia, acute leukemia, and other blood abnormalities. For leukemia, the risk seems linked to cumulative exposure, but individual susceptibility is key. Only a minority of heavily exposed people get sick, suggesting a genetic component.
So checking employment history is important.
Crucial, especially in industries using benzene as a solvent or in manufacturing. Thankfully, industrial regulations have drastically reduced benzene-related blood diseases. But we can still get low-level exposure from metabolites in the environment or diet. For other chemicals, the link to marrow failure is much less proven than for benzene.
And then there are drugs. We know chemo drugs suppress marrow predictably. But what about these other unpredictable reactions?
Right. Chemo causes dose-dependent marrow suppression, that's expected. But then you have these idiosyncratic reactions to a whole range of other common drugs where there's no clear dose response. We're talking non-steroidal anti-inflammatories, sulfa drugs, some thyroid meds, psychotropics, penicillamine, allopurinol, gold compounds. The list is pretty long.
Idiosyncratic meaning it's not the dose, but some kind of individual, unpredictable reaction. That must make it hard to pin down.
Exactly. And it highlights the tricky difference between association and causation. Was the drug given to treat the first symptoms of the marrow failure that was already starting, like antibiotics for a fever?
I see.
Or did the drug just unmask a pre-existing problem, like an NSA causing bruising in someone who already had low platelets? While devastating for the individual, these idiosyncratic reactions are incredibly rare overall. Even if a drug increases the risk 10 or 20-fold, that might still only translate to a tiny number of cases out of hundreds of thousands exposed. It's like drawing a very unlucky genetic card.
What role do infections play? Can they trigger aplastic anemia?
Well, mild temporary dips in blood counts are actually pretty common during many routine viral or bacterial infections, just a temporary slowdown. More seriously, aplastic anemia can rarely follow infectious mononucleosis. Parvovirus B19, though, typically causes pure red cell aplasia hitting just the red cells, not usually the generalized marrow failure of aplastic anemia.
Are there specific immune system diseases linked to aplasia?
Yes. A major one is transfusion-associated graft versus host disease, or GVHD. That's where immune cells from transfused blood attack the recipient's tissues, including the marrow. It can be fatal. Other links include eosinophilic fasciitis, thymoma, a thymus tumor, hypoimmunoglobulinemia, low antibodies, and sometimes SLE or lupus. Pancytopenia with a hypoplastic marrow can be seen there too.
The text mentions post-hepatitis marrow failure as a significant cause, about 5%. What's the story there? Sounds like a delayed severe reaction.
It is notable. Typically, it affects young men who are recovering from hepatitis, usually a type that isn't A, B, or C, so seronegative hepatitis about 1 or 2 months earlier. The pancytopenia that follows is often extremely severe. Despite intense searching, no specific virus has been consistently found, so the thinking is that both the hepatitis and the subsequent marrow failure are immune-mediated. There's also a link to kids who've had fulminant liver failure. They have a high rate of developing marrow failure later, suggesting maybe a shared underlying immune issue.
Is there any link with pregnancy?
Yeah. Very rarely, yes. Aplastic anemia can occur or even recur during pregnancy. And interestingly, it often resolves after delivery or termination of the pregnancy. The hormonal and immune changes are likely involved somehow.
Okay, now paroxysmal nocturnal hemoglobinuria, PNH. There seems to be a really fascinating complex connection there with aplastic anemia.
Oh, absolutely. It's a pivotal link. PNH requires an acquired mutation in a gene called APHA happening within a hematopoietic stem cell. These mutations probably happen fairly often in normal people, actually.
Really?
Yeah, but if that PKA mutant stem cell starts proliferating, it creates a clone of blood cells that are missing certain proteins on their surface. This makes them vulnerable to destruction, leading to PNH symptoms. What's truly intriguing is that using sensitive tests like flow cytometry, we can detect small clones of these PNH-type cells in more than half of patients with aplastic anemia when they're first diagnosed.
More than half, wow. So what does that tell us? What's the implication for the immune system's role here?
It strongly suggests a shared immunological landscape. It implies the immune attack that's happening in aplastic anemia might somehow select for these PNH clones, perhaps because they're more resistant to that specific immune attack, allowing them to survive and even expand.
So it's a two-way street. PNH patients can develop aplasia, and aplastic anemia patients can develop PNH.
Precisely. Even PNH patients whose main problem is hemolysis, red cell destruction, often show underlying defects in their bone marrow function. And younger PNH patients can later develop full-blown aplasia. Conversely, patients first diagnosed with aplastic anemia, even years after their counts recover with treatment, can sometimes develop hemolytic PNH later on. This strong back and forth really reinforces the idea of an underlying immune process that can manifest differently, targeting the marrow stem cells but potentially allowing these PNH clones to emerge.
Let's dig into those constitutional syndromes, the inherited predispositions. Fanconi anemia sounds like a major one. How does that present?
Fanconi anemia is an autosomal recessive disorder, meaning you need 2 copies of the faulty gene. It typically shows up with a mix of congenital developmental anomalies, progressive pancytopenia over time, and a much higher risk of developing cancers.
Is there a specific diagnostic test?
Yes, a very specific one. You expose the patient's chromosomes to DNA cross-linking agents. In Fanconi anemia, the chromosomes show characteristic breakage patterns because they can't repair that type of damage properly.
And what physical features might clue a doctor in? Any outward signs?
Often, yes. Short stature is common. Distinctive café au lait spots on the skin. Anomalies of the thumbs may be absent or malformed, or the radius bone in the forearm. Genitourinary tract issues, too. There are actually many different genes involved, at least 17, but most of them work together in a pathway crucial for repairing DNA damage, specifically those interstrand crosslinks. When that repair pathway is broken, cells are vulnerable, they die, and eventually the marrow fails. The factory machinery can't fix itself.
Are there other inherited conditions maybe affecting different parts of the cell's machinery, like ribosomes?
Yes. Diamond-Blackfan anemia and Shwachman-Diamond syndrome are called ribosomopathies. They involve genetic defects in how ribosomes, the cell's protein factories, are assembled. This causes tissue-specific problems. Schwachman diamond, for instance, often presents early with neutropenia, low white cells, problems with the pancreas leading to poor digestion, and usually involves mutations in the SBDS gene.
And telomeropathies. That sounds like it involves the ends of chromosomes, the telomeres that protect our DNA. How do problems there lead to marrow failure?
You got it. Telomeres are like the plastic tips on shoelaces, protecting the ends. In telomeropathies, inherited genetic defects mess up telomere repair, or the sheltering proteins that guard the telomeres. A classic example is dyskeratosis congenita, often seen in kids. It has this triad: mucous membrane leukoplakia, white patches, dystrophic nails, and reticular skin hyperpigmentation, plus early onset aplastic anemia.
What causes that?
It's due to mutations in genes involved in the telomere repair complex, which maintains telomere length as cells divide. Genes like DKC1, TERK, an RNA template, or sometimes TNF2, a shelterin protein. If telomeres get too short or aren't protected, cells stop dividing or die. In the bone marrow, that leads to failure. The cells basically reach their expiration date way too early.
Do these telomere problems only show up in childhood, or can adults get diagnosed too, maybe with less obvious signs?
Absolutely can present in adults, and that's a key diagnostic point. Mutations in TERK, and especially TERT, the enzyme telomerase itself, can have subtler effects. Adults might present mainly with thrombocytopenia, low platelets, rather than full pancytopenia. They might not have the obvious physical anomalies.
Any subtle clues then?
Early hair graying. Before age 30, that's a big clue. A detailed family history might also reveal things like pulmonary fibrosis or liver cirrhosis in relatives, as these can also be part of the syndrome complex. Penetrance is variable, meaning not everyone with the mutation gets severe disease, making these mutations more like strong risk factors. But measuring telomere length in blood cells is a functional test that's available and can be very helpful here.
Okay, let's shift to the core pathophysiology. Marrow failure means severe damage to the blood-forming cells. What does that damage look like microscopically? What are the consequences?
Visually, in aplastic anemia, the marrow gets replaced by fat. You see it clearly on a biopsy or even an MRI of the spine. The normal red active marrow is gone, just fatty tissue left. Cellularly, if you look for CD34 positive cells markers for those early stem and progenitor cells, they're drastically reduced. Functional lab tests show the progenitor pool is practically non-existent. In severe cases, it might be down to 1% or less of normal. The factory floor is essentially empty.
And in those constitutional genetic syndromes, how does the inherited defect specifically cause that emptiness?
In those cases, it's an intrinsic problem with the stem cells themselves. The blueprint is faulty. In Fanconi anemia, it's that broken DNA repair pathway cells die when exposed to certain stresses. In telomeropathies, the inability to maintain telomeres limits how many times the cells can divide. They just wear out prematurely. And with mutations in genes like GATA or RUNX, the fundamental instructions for making blood cells, the transcriptional regulation, are disrupted.
So those are built-in problems. What about damage from the outside? Massive radiation or chemical hits, and how do those weird idiosyncratic drug reactions fit in?
Right. Extrinsic damage can definitely happen from massive insults, high-dose radiation, toxic chemicals where the damage is direct and widespread. But for those more common, unpredictable, idiosyncratic reactions to fairly normal drug doses, the thinking is it often involves altered drug metabolism.
How so?
Many drugs get broken down in the body into highly reactive intermediate compounds. These intermediates can be toxic because they readily bind to important molecules like DNA and proteins. Benzene's toxicity, for example, comes from its breakdown products, hydroquinones and quinolones. Whether someone develops toxicity might depend on their genetics. Maybe they produce too much of the toxic intermediate, or maybe they can't detoxify it efficiently. This genetic variability could explain why these reactions are so rare, occurring only when a susceptible individual encounters that specific drug challenge. It's not just the drug, it's your specific biochemical makeup reacting to it.
That's fascinating. Now, this idea that aplastic anemia might often be immune-mediated, how did that idea even come about? It sounds like a shift from thinking it was just toxic damage.
The first big clue came from an unexpected observation. Some patients being prepared for a bone marrow transplant who were given a drug called anti-lymphocyte globulin, or ATG, which targets immune cells. Specifically, lymphocytes actually had their own marrow function recover.
Wait, giving an immune-suppressing drug made their own marrow work again?
Exactly. If you knock down the immune cells and the marrow recovers, that strongly points the finger on the immune system as the culprit attacking the marrow.
So what's the lab evidence backing this up? How do we actually see the immune system attacking the factory?
There's solid lab data. For instance, if you take blood or marrow cells from an aplastic anemia patient and put them in a dish with normal marrow cells, the patient's cells can actually suppress the growth of the normal cells.
Oh.
And conversely, if you remove the T cells, key immune orchestrators, from the patient's marrow sample, the remaining hematopoietic cells often grow much better in the lab. This directly implicates T cells in the destruction.
What's the mechanism? How are the T cells killing the stem cells?
It seems immune signaling molecules, specifically type 1 cytokines like interferon gamma, IFN null, play a big role. IFN triggers stem cells, the CD34 positive cells, to express a death receptor called PHA on their surface. This basically marks them for apoptosis, programmed cell death. There's also evidence that some stem cells might survive by losing their HLA markers, making them invisible to the immune attack, which might explain the PNH clones we discussed.
So why doesn't everyone who gets exposed to a potential trigger, like a virus or certain drugs, develop aplastic anemia if it's immune-mediated?
That's the million-dollar question. It likely comes down to subtle genetic variations in the individual's immune system, differences in HLA types, cytokine genes, regulators of T-cell responses. These genetic differences might make certain people prone to turning a normal temporary immune response into a sustained destructive autoimmune attack on their own bone marrow.
A complex mix of genetics and triggers leading to self-attack. Okay, given all this, what does aplastic anemia typically look like clinically? What do you ask about in the history? How do patients usually present?
It can come on suddenly or creep up slowly. The most common first sign is often bleeding due to low platelets, easy bruising, gum oozing, nosebleeds, heavy periods, maybe those tiny red spots called petechiae. While massive bleeding is uncommon just from low platelets, even small bleeds in the brain or eye can be catastrophic.
What about anemia symptoms?
Also very common. Fatigue, weakness, feeling breathless, maybe a pounding sound in the ears because the heart's working harder.
Is infection usually the first sign?
Interestingly, no. Unlike some other marrow failure states like granulocytosis, where infection hits early and hard, infection is unusual as the first symptom in aplastic anemia. Patients often feel surprisingly well initially, despite really low counts. Pallor might be the most obvious thing. Systemic symptoms like fever or weight loss should make you think of other diagnoses.
So what do you need to ask about specifically?
You really have to probe. Ask detailed questions about all prior drug use, any chemical exposures, recent viral illnesses. And family history is key, any blood diseases. But also things like pulmonary or liver fibrosis, early hair graying, those could point to a telomeropathy. Or a history of unusual infections or warts might suggest GATA2 deficiency.
And the physical exam, what clues are you looking for there, especially for those constitutional syndromes?
You'll typically see the petechiae and bruises, so you need to examine gently. Pallor is common. Bleeding signs might be present. Crucially, lymph nodes shouldn't be enlarged, and the spleen shouldn't be palpable. If they are, think of other diagnoses like leukemia or lymphoma. But look for those specific anomalies suggesting inherited conditions. The café au lait spots and short stature of Fanconi, the weird nails and mouth patches of dyskeratosis congenita, early graying for telomere issues, skin warts for GATA2. These physical clues can be invaluable.
Moving to the labs, what does the blood work show? What are the key features on the blood smear itself?
Okay, the smear typically shows large red cells macrocytosis, even though production is failing. You'll see very few platelets and granulocytes. The MCV, mean corpuscular volume, is usually high. But the absolute key finding is the lack of reticulocytes. Those immature red cells are absent or very low, confirming the marrow isn't responding to the anemia. Lymphocyte counts might be normal or low.
What findings would point away from aplastic anemia on the smear?
If you see immature myeloid cells like blasts, that screams leukemia or MDS. Nucleated red blood cells suggest marrow fibrosis or maybe tumor infiltration, and funny-looking platelets, really large ones, or ones lacking granules, point more towards peripheral destruction or MDS, where the factory makes faulty product.
And the bone marrow exam itself, that's the definitive look at the factory floor, right?
What you expect.
It is definitive. Usually you can aspirate the marrow okay, but the sample looks really dilute, watery, because there are so few cells. The biopsy core might look pale, fatty, not the normal deep red. If you get a dry tap, can't aspirate anything that actually suggests fibrosis or myelodysplasia, not typically aplasia. What does the aplastic marrow look like under the microscope?
The aspirate smear just shows residual red cells, lymphocytes, maybe some stromal cells, but hardly any actual blood-forming cells. The biopsy is key for cellularity. It shows mostly fat, with hematopoietic cells making up less than 25% of the space, sometimes virtually none. Cellularity doesn't always perfectly match the blood counts, though. You can have hot spots of residual activity. Any remaining cells should look morphologically normal, though maybe slightly megaloblastic. Megakaryocytes, the platelet precursors, are usually gone or greatly reduced. Finding granulomas might suggest an infection like TB is the cause.
Beyond the standard test, what other ancillary or genomic studies are crucial for a precise diagnosis, especially telling acquired from inherited forms apart?
Okay, several important ones. Chromosome breakage studies using agents like dipoxybutane are essential for all kids and younger adults to rule out Fanconi anemia.
That specific test again.
Yes. Measuring telomere length. Very short telomeres strongly suggest a telomerase or shelter-in mutation, triggering family studies and gene sequencing. Chromosome analysis, cytogenetics, of the marrow cells themselves, typically normal in aplastic anemia, but often abnormal in MDS, a key distinction. Flow cytometry is vital for detecting those PNH clones. Serology can check for recent viral infections like EBV or HIV, though remember, post-hepatitis aplasia is usually seronegative.
And how has next-generation sequencing, NGS or genomics, changed the game here? How does it help dissect the genetics?
NGS has been a massive advance. We can now sequence large panels of genes looking for pathogenic mutations. It's crucial for distinguishing acquired versus inherited forms and aplastic anemia versus MDS. Germline panels check 50-plus genes known to cause constitutional marrow failure, vital for kids and adults with suspicious features or family history, as these can present late.
And for suspected MDS.
Then you use somatic mutation panels, often called myeloid neoplasm panels, querying maybe 100 genes commonly mutated in MDS and AML. This is key because finding mutations in certain genes, like spliceosome genes, SF3B1, or cohesion family genes, strongly points towards MDS, whereas you wouldn't expect them in typical immune-mediated aplastic anemia. It provides molecular-level diagnostic clarity.
So after all these tests, is the diagnosis of aplastic anemia usually clear-cut, or are there still diagnostic gray areas?
Usually it's pretty straightforward. Pancytopenia plus a fatty hypocellular marrow. Especially in a young person, it should be a leading diagnosis. And usually if the pancytopenia is secondary to something else like advanced cirrhosis with a huge spleen, metastatic cancer, lupus, miliary TB, that primary cause is fairly obvious from the history exam or other tests.
But the text emphasizes the challenge of differentiating it from related blood disorders, especially hypocellular MDS. That distinction sounds critical for treatment choices. How do you tell them apart?
That's where the real nuance comes in, requiring expert interpretation. Remember, patients might start with only 1 or 2 cell lines down before progressing. The 2 biggest challenges are distinguishing acquired versus constitutional aplasia and aplasia versus MDS. Constitutional forms often have that suggestive history or physical findings, but the marrow can look identical, except maybe GANA too. Genomic testing is the definitive discriminator for inherited forms, but results take time, which is tough when treatment is urgent.
And specifically, separating aplastic anemia from hypocellular MDS. What leans you towards MDS?
Morphological abnormalities, funny-looking megakaryocytes or myeloid precursors strongly favor MDS. Finding typical MDS-related cytogenetic abnormalities or specific somatic mutations on genomic screening also points towards MDS. There's still a fuzzy border, though. Some low-risk MDS cases, like those with certain chromosome deletions, 13q, 20q, can actually respond to immunosuppression like aplastic anemia does. And some mutations, like in DNMT3A or ASXL1, can be seen in both conditions, blurring the lines. Expert hematopathology and genomic interpretation are absolutely essential here.
Okay, let's talk prognosis and treatment. If severe aplastic anemia is left untreated, what happens? And what factors predict the outcome?
Untreated severe aplastic anemia. The natural history is rapid decline and usually death. The factory just completely shuts down. Historically, transfusions and antibiotics helped manage complications, but spontaneous recovery was incredibly rare. The main predictor of outcome is the severity of the blood counts. Classically, severe disease meant having 2 out of 3, neutrophils below 500, platelets below 20,000, and a corrected reticulocyte count below 1%.
Are there better predictors now with modern therapies?
Yes, in the era of effective immunosuppression, higher absolute reticulocyte counts, say above 25,000, and higher lymphocyte counts, maybe above 1,000, seem to be better predictors of response to treatment and long-term survival. They suggest some residual marrow function or maybe an immune profile that responds better.
Any other prognostic factors beyond counts, genetic or cellular clues?
Definitely. Having a PNH clone, even a small one, paradoxically often correlates with a better response to immunosuppression, likely because it indicates an immune-mediated process. Very short telomeres suggest diminished stem cell reserve, premature aging of the marrow, and risk of instability. And finding mutations typically seen in myeloid cancers like ASXL1 or DNMT3A, even if it's just clonal hematopoiesis, is associated with a worse prognosis and higher risk of evolving into MDS or leukemia later. These genetic markers are becoming increasingly important.
So for treatment of severe acquired aplastic anemia, what are the main strategies? Sounds like two distinct paths.
Essentially, yes. You can either try to replace the failed marrow and immune system with a hematopoietic stem cell transplant, HSCT, aiming for a cure by installing a new factory. Or you can try to ameliorate the condition by suppressing the immune attack, hoping the patient's own residual marrow function can recover, essentially giving the existing factory a chance to restart. Glucocorticoids, by the way, are not primary therapy on their own. Any suspected drug or chemical exposure should stop immediately, but you usually can't afford to just wait and see if it gets better spontaneously if the counts are severely low.
Let's break down HSCT first. Sounds like the top choice for younger patients if they have a matched sibling donor.
It is. For younger patients with a fully matched sibling, transplant is the first choice, offering the best chance of a cure. HLA typing needs to be done urgently as soon as the diagnosis is made. It's also critical not to transfuse blood from family members to potential transplant candidates to avoid sensitizing them against HLA antigens, which could cause rejection later. All blood products should be leukocyte depleted for the same reason.
What are the outcomes like?
For kids transplanted from matched siblings, long-term survival is excellent, around 90%. Outcomes are less good for adults, mainly due to higher risks of chronic graft versus host disease, GVHD, and infections. Still, transplant should be considered early for most, even older patients if they're fit enough, and using alternative donors if no sibling match exists.
What if there's no matched sibling? What are the alternative donor options for transplants?
Most patients don't have a matched sibling, so we look elsewhere. Matched unrelated donors from large international registries are an option for many, especially Caucasians. With high-resolution matching, outcomes can be similar to sibling transplants, though maybe with more complications. Cord blood is another source, especially for kids. And increasingly popular are HLA haploidentical family donors, half-matched relatives like parents or children. A donor is almost always available quickly this way. Techniques like post-transplant cyclophosphamide are making these much safer and more effective by preventing severe GVHD. Importantly, modern transplant protocols for aplasia usually avoid total body radiation to reduce the risk of late secondary cancers.
Okay, so if transplant isn't the plan, or maybe as first line for others, immunosuppression, IS, is the alternative, aiming to calm the immune attack. What's the standard IS regimen?
The standard is a combination of anti-thymocyte globulin, ATG, plus cyclosporine. This potent combo induces hematologic recovery, meaning transfusion independence and safe white cell counts in about 60-70% of patients. Kids do particularly well. Older adults might struggle more with side effects due to other health issues. A strong early response usually predicts better long-term survival. You typically see granulocyte counts start improving within about 2 months.
That recovery usually lasts. Is relapse a concern? And what about this clonal evolution risk you mentioned earlier? Sounds like a serious long-term issue.
Recovery can be slow, and relapse is definitely a concern. Even recovered patients often have counts that aren't perfectly normal, maybe a high MCV, and marrow cellularity comes back very slowly, if at all. Relapse pancytopenia returning happens frequently, often when cyclosporine is tapered. Restarting immunosuppression often works again, but some patients become dependent on cyclosporine long-term. And then there's clonal evolution.
Right, the development of new problems later.
Yes. Over about a decade after starting ATG, roughly 15% of treated patients develop new chromosomal abnormalities, sometimes progressing to full-blown MDS with abnormal marrow cells, or even acute leukemia. This is often associated with worsening blood counts again. It seems the immunosuppression, while allowing recovery, might also create an environment where abnormal, treatment-resistant clones can emerge and take over later.
So the immune therapy clears the way, but potentially for these abnormal clones too. That's quite a trade-off.
It is. And remember the PNH connection. We often detect PNH clones at diagnosis. After IS, these clones can sometimes expand, and patients might even develop hemolytic PNH symptoms. It's crucial to monitor patients long-term with regular blood counts and repeat bone marrow exams if counts change unfavorably to catch this clonal evolution early.
What are the practicalities and side effects of ATG and cyclosporine that patients and doctors need to manage?
Horse ATG is given by IV infusion, usually requiring hospitalization for monitoring. Rabbit ATG, interestingly, seems less effective, maybe because it hits regulatory T cells too hard. A common side effect of ATG is serum sickness. About 10 days after starting, patients can get a flu-like illness, rash, joint pain. Methylprednisolone is given alongside ATG to lessen these reactions, but you have to be careful with prolonged steroid use due to risks like a vascular necrosis. Cyclosporine is taken orally, with dose adjusted based on blood levels. Key side effects are kidney toxicity, high blood pressure, and sometimes seizures, so close monitoring is essential.
So for patients without a donor, IS is the main option. But how does it stack up against transplant overall? If an adult does have a matched sibling, how do you choose?
It's interesting, overall survival rates between transplant and IS are actually pretty similar. But transplant offers a cure, a complete replacement. IS leads to recovery, but patients remain at risk of relapse or clonal evolution. The decision for an adult with a matched sibling often comes down to age and how severe the neutropenia is. Older patients might do better with IS because transplant risks are higher for them. But if the neutropenia is profound, life-threateningly low, transplant might be preferred for a more definitive fix. Importantly, even if IS fails, patients can often still be successfully transplanted later, so the options aren't always mutually exclusive.
What about those standard hematopoietic growth factors, EPO and GCSF? Do they help boost counts in aplastic anemia?
Generally, no, surprisingly. Unlike in some other conditions, EPO and GCSF aren't very effective in aplastic anemia. The reason is likely that the patient's own endogenous levels of these hormones are already sky high. The body is screaming at the marrow to produce, but the factory is too damaged or suppressed to respond. It's like flooring the accelerator when the engine is broken.
But there's one specific drug, eltrombopag, a thrombopoietin mimetic, that seems to be a major exception. What does it do differently?
Yes, eltrombopag has been a real game changer. It showed unexpected and remarkable activity, especially in patients refractory to other treatments. It produced robust, often durable improvements across all 3 cell lines: red cells, white cells, and platelets.
How does it work?
The main thinking is that, as a thrombopoietin mimetic, it directly stimulates the hematopoietic stem cells themselves, not just one lineage. It might also have other benefits like chelating iron or boosting regulatory T cells, potentially dampening the immune attack. Adding eltrombopag to the standard first-line IS regimen of horse ATG and cyclosporine significantly boosted response rates, overall response up to around 80%, complete response around 50%. It's now FDA approved for refractory disease and, as part of initial therapy, a major step forward.
Any role for older therapies like androgens, maybe for milder cases or specific genetic types?
Androgens. Their effectiveness isn't proven in large controlled trials, but anecdotally, some patients do respond or seem dependent on them. One hypothesis is they might boost telomerase activity, which could be beneficial, especially for patients with known telomere defects. So for moderate disease, particularly if a telomere issue is suspected, a 3-4 month trial might be considered.
Beyond the specific drugs or transplant, how vital is supportive care in keeping patients going?
Absolutely fundamental. Meticulous supportive care is crucial for survival, allowing patients time to respond to definitive therapy or maintaining quality of life if treatment fails. First priority: aggressive infection management in neutropenic patients. That means prompt, broad-spectrum IV antibiotics, started empirically, don't wait for cultures. Actively look for infection sources: throat, sinuses, gut, catheter lines. Add vancomycin for suspected line infections. If fever persists despite antibiotics, suspect fungal infection candida. Aspergillus are common, and start antifungals early.
Have improvements in infection control made a difference?
Huge difference. Better antifungal drugs and using them proactively have significantly improved outcomes. Granulocyte transfusions can sometimes help bridge severe infections, and simple things like rigorous hand washing remain critical. Things like gut decontamination with non-absorbed antibiotics or reverse isolation haven't really proven effective.
What about transfusion support, managing low red cells and platelets? Any challenges there, like alloimmunization?
Yes, maintaining platelet and red cell counts with transfusions is often a lifeline. Alloimmunization, developing antibodies that make future transfusions ineffective, used to be a huge problem with platelets. Now, strategies like using single donors and leukocyte reduction drastically minimize this risk. If patients do become refractory, HLA-matched platelets can often overcome it. Drugs to reduce bleeding haven't proven very effective, nor has low-dose steroid use for vascular stability.
And for red cell transfusions, what are the guidelines, and what about long-term iron overload?
Red cells are usually transfused to maintain a reasonable activity level, aiming for a hemoglobin around 7 GDL, maybe 9 GDL if they have heart or lung disease. A typical schedule might be 2 units every couple of weeks for someone with no marrow function. But the big long-term issue is iron overload from all those transfusions. So after about 50 units or so, iron chelation therapy using drugs like deferoxamine or deferocearox becomes essential to remove excess iron and prevent damage to organs like the heart and liver.
That covers aplastic anemia in incredible detail, the empty factory. Now, let's look at a more focused problem. Pure red cell aplasia, or PRCA. Sounds like just one specific production line is down here.
It is exactly that. PRCA is defined by anemia, very low reticulocytes, reticulocytopenia, and specifically an absence or near absence of erythroid precursors, the cells destined to become red blood cells in the bone marrow. The key difference from aplastic anemia, or MDS, is that the other cell lines, the white cells and platelets, look perfectly normal, both in number and appearance. It's a specific shutdown of just the red cell factory line.
Is it always acquired in adulthood, or can it be inherited too?
Both. While typically acquired in adults, there's a constitutional form, Diamond-Blackfan anemia or congenital PRCA. It's diagnosed usually at birth or early childhood, often responds well to steroids, and we now know it's caused by mutations in genes involved in ribosome production. There are also temporary forms of red cell failure, like the transient aplastic crisis caused by parvovirus B19 in patients with underlying hemolysis, or a condition called transient erythroblastopenia of childhood, which affects normal kids but resolves spontaneously.
What are the main causes or associations of acquired PRCA in adults, often linked to immune issues?
Yes, there are important links to the immune system. A minority of cases are associated with thymoma, a tumor of the thymus gland. More often, PRCA can be a sign of large granular lymphocytosis, LGL, a type of white blood cell disorder, or it can complicate chronic lymphocytic leukemia, CLL. Some patients might also have low antibody levels, hypogammaglobulinemia. And interestingly, the 5q syndrome, a type of MDS, can sometimes present mainly as red cell aplasia due to the loss of a ribosomal protein gene, showing genetic overlaps.
Can drugs cause PRCA too? And what's this about EPO treatment itself causing it? That sounds counterintuitive.
Idiosyncratic drug reactions can occasionally cause PRCA, yes, but the critical, surprising one is EPO-induced PRCA. Giving subcutaneous EPO, the very hormone meant to stimulate red cell production, can sometimes provoke the body to make neutralizing antibodies against EPO. The immune system attacks the treatment itself, shutting down red cell production. It's a rare but serious complication. PRCA can also happen after stem cell transplant due to antibodies against blood group antigens. But for most idiopathic cases, the underlying mechanism is likely T-cell-mediated inhibition of erythropoiesis, similar to aplastic anemia but targeted specifically at the red cell line.
Parvovirus B19 sounds like a really important cause to identify because it's treatable. Why is this virus so good at shutting down red cell production?
Absolutely. Parvovirus B19 is common, causes fifth disease in kids, joint pain in adults. In people who already have high red cell turnover, like those with hemolytic anemias, parvovirus infection can trigger a transient aplastic crisis, a temporary, abrupt halt in red cell production, making their anemia suddenly worse. This happens because the virus specifically targets and kills rapidly dividing erythroid progenitor cells.
Okay, so it hits those with underlying conditions harder. Why doesn't it cause chronic problems in most people? And how does it cause persistent infection and chronic PRCA in some?
In healthy people, the immune system quickly makes neutralizing antibodies and clears the virus. But in individuals with weakened immune systems, congenital, acquired like HIV or iatrogenic like post-transplant immunosuppression, the virus can persist. This leads to chronic PRCA. The marrow shows red cell aplasia, and you see these characteristic giant pronormoblasts, huge abnormal red cell precursors, which are a direct sign of the viral damage.
How does it target those cells so specifically?
It uses the erythrocyte P antigen, which is present on erythroid progenitor cells, as its doorway, its receptor to get into the cells. Its direct killing effect causes anemia if red cell demand is high. In normal folks, the brief shutdown isn't noticed clinically. The rash and joint pain are actually caused by immune complexes, not marrow failure.
Given that parvovirus is treatable, how is PRCA managed overall? What's the diagnostic approach and what therapies work?
First step is a thorough workup history, physical basic labs to look for underlying causes like thymoma, LGL, CLL, drug exposure, or immune deficiency. If thymoma is suspected, imaging is needed, surgery is indicated, though the anemia doesn't always resolve. To diagnose persistent parvovirus, you need to detect the viral DNA itself, often by PCR in the blood, because antibody tests can be negative in immunocompromised patients. Finding erythroid colonies growing in marrow culture used to be seen as a good sign for response to immunosuppression in idiopathic cases.
And the treatments.
Supportive care transfusions plus iron chelation can allow patients to live reasonably well long term. If persistent parvovirus B19 is confirmed, intravenous immunoglobulin, IVIG, is highly effective, clearing the virus in almost all cases. For most other acquired PRCA cases, especially idiopathic ones, immunosuppressive therapy is the mainstay. Glucocorticoids, cyclosporin, ATG, azathioprine, cyclophosphamide, these can often successfully dampen the immune attack and allow red cell production to recover.
Okay, let's pivot now to the myelodysplastic syndromes, MDS. This sounds less like an empty factory or a specific gap, and more like a disordered factory making faulty parts, and with a risk of things going really wrong, like turning into leukemia.
That's a perfect description. MDS is a really heterogeneous group of blood disorders. The key features are cytopenia's low blood counts because of bone marrow failure, but it's a failure of effective production. And alongside that, there's a significant risk of progressing to acute myeloid leukemia, AML.
So the marrow is busy but making bad cells.
Exactly. You get anemia because the red cells being made, erythropoiesis, are ineffective, they're faulty, and die off prematurely. Often, you also get low platelets, thrombocytopenia, and low neutrophils, neutropenia. Under the microscope, the bone marrow cells look abnormal, dysmorphic. The marrow itself is usually cellular or even hypercellular, packed with cells, but they're not maturing properly. Or there might be specific chromosome abnormalities or acquired genetic mutations driving it. The factory is churning out defective products.
Is MDS always high risk? Does it always head towards leukemia?
No, it's definitely a spectrum. In what we call low-risk MDS, the main problem is the marrow failure itself, managing the anemia, infections, bleeding risk from the cytopenias. But in high-risk MDS, you see more immature cells, myeloblasts in the marrow from the start, chromosome abnormalities are common, and the biggest worry becomes a high chance of progressing to AML.
What do patients with MDS typically die from? Is it always the leukemia?
It can be fatal, often from complications of the pancytopenia infections, bleeding, or from the progression to leukemia. But because MDS is primarily a disease of the elderly, a large number of patients actually die from other concurrent health problems typical of aging. So while MDS is serious, it might not always be the direct cause of death.
The way MDS is classified seems to have changed a lot over the years, from FAB to the current WHO system.
Yeah.
What drove those changes?
Our understanding has just deepened dramatically. The original French-American-British FAB classification from the 80s was useful, defining 5 subtypes. But the World Health Organization, WHO classifications, starting in 2002 and revised since, reflect more biological understanding. For example, the WHO recognized the line between high-risk MDS, RAEBT, and AML was a bit arbitrary and set the 20% blast threshold to define AML. It also clarified that CMML behaves more like a myeloproliferative disease, an overproduction issue.
And the current WHO classification from 2016 sounds like genomics really became central then.
Absolutely. The 2016 WHO classification is more refined and, yes, more complex. Blast percentage is still critical for defining categories. Some leukemias that are predominantly red cell precursors are now considered MDS. Specific defining chromosome abnormalities remain key. But the big change is the integration of genetics. For instance, having a specific somatic mutation in the SF3B1 gene is now a defining feature for MDS subtypes with ring sideroblasts. Identifying these specific mutated genes is becoming increasingly vital for classification, predicting prognosis, and even guiding targeted therapies. We're moving beyond just how cells look to their actual genetic blueprint.
It sounds like diagnosing MDS can still be tricky, even for specialists. Why is it such a puzzle, even with all these tools?
It really can be. Making the diagnosis requires recognizing subtle clinical and pathological features, and accurate classification needs a hematopathologist who's up to date with the latest criteria. But even then, there's some subjectivity. Pathologists might not always agree perfectly on the subtle morphological changes, especially in granulocytes or red cells. Changes in megakaryocytes tend to be a bit more reliable.
What else complicates the diagnosis? Can normal aging or other conditions mimic MDS?
Yes. Dysplastic changes, those abnormal cell appearances, can sometimes be seen in healthy individuals, or temporarily due to things like B12 or folate deficiency, certain drugs or toxins. That's why follow-up is crucial. And genomics, while powerful, adds its own complexity. Is a detected mutation somatic, acquired, or germline inherited? Is it truly pathogenic or of unknown significance? Then there's clonal hematopoiesis, age-related expansion of certain blood cell clones with mutations which might be harmless or might increase future risk. Interpreting the significance of these clones and their size is challenging.
So given these challenges, why is it so important for primary care doctors to suspect MDS and refer quickly to a hematologist?
Because early, accurate diagnosis is key. There are newer therapies now that can genuinely improve blood counts, slow disease progression, and improve quality of life. But choosing the right therapy, managing side effects, providing optimal supportive care that requires specialist expertise. Delaying referral can limit options and impact outcomes.
Let's talk epidemiology. Who typically gets MDS? Is it mostly older adults?
Yes, overwhelmingly, MDS is a disease of the elderly. The average age at diagnosis is over 70. There's a slight male predominance. It's actually quite common in older populations. Incidence rates can be 500 per million or even higher in those over 70. While overall rates are maybe 40,000 new cases a year in the U.S., the prevalence is much higher because people can live with it for years. And rates have likely increased due to better recognition and the aging population.
Is it seen often in children?
No, MDS is rare in children. When it does occur, it often points towards an underlying inherited genetic predisposition that can be picked up with genomic testing.
What about secondary or therapy-related MDS? Does that fall in the same age pattern?
No, that's different. Therapy-related MDS isn't tied to age in the same way. It's a direct consequence of prior exposure to chemotherapy or radiation, often given years earlier for a different cancer.
Okay, shifting to the roots of MDS, the etiology and pathophysiology. What causes this factory to become so disordered?
Well, like aplastic anemia, it's linked to environmental exposures like radiation and benzene, though other risk factors are less consistently reported. Therapy-related MDS is clearly linked to prior cancer treatments, alkylating agents, radiation, often with a 5-7 year lag, or to topoisomerase inhibitors, shorter, maybe 2-year lag.
Can it develop from other marrow problems?
Yes. Acquired aplastic anemia, Fanconi anemia, other constitutional marrow failure syndromes can all evolve into MDS over time. And sometimes adult MDS turns out to be linked to an underlying germline mutation in genes like GATA2, RUNX1, or telomere genes that maybe didn't cause obvious problems until later in life.
But for the typical elderly patient with MDS, without a clear exposure or prior history, what's the current thinking on its origin?
For most typical cases, we don't find a specific trigger. It's largely viewed as a disease of aging. The idea is that mutations gradually accumulate within a hematopoietic stem cell over decades, happening within the context of an aging bone marrow environment. Think of it like cellular wear and tear leading to errors in the factory's master plan.
Can you elaborate on MDS being a clonal stem cell disorder? What does that mean for the cells and their genetic stability? How does one bad clone lead to both low counts and leukemia risk?
Right. Clonal means it starts from a single abnormal hematopoietic stem cell that acquires a mutation or genetic hit. This cell then outcompetes the normal cells and expands, creating a clone of defective progeny. This leads to disordered proliferation, impaired differentiation, cells don't mature right, and ineffective hematopoiesis resulting in the low blood counts, cytopenias. But because these clonal cells are often genetically unstable, they're prone to acquiring more mutations over time, which drives the progression towards acute myeloid leukemia.
Is this linked to chromosome problems?
Yes, both chromosomal instability and specific gene mutations are involved, and both increase with age. About half of MDS patients have detectable cytogenetic abnormalities, often chromosome loss or gain, aneuploidy, rather than translocations. Shortening telomeres might contribute to this genomic instability. And these abnormalities aren't random. Specific patterns like loss of parts of chromosome 5, 7, or 20, or gaining chromosome 8 are common and correlate strongly with prognosis, especially the risk of leukemia.
How has genomics deepened our understanding of the specific mutations and pathways involved? This seems like where the real action is in understanding MDS now.
Genomics has been revolutionary here. We can now identify somatic mutations, acquired mutations in the marrow cells in around 100 different genes known to be recurrently altered in myeloid cancers. Many overlap with AML, but some are more specific to MDS subtypes. The prime example is SF3B1 mutations being strongly tied to sideroblastic anemia. This genetic information helps pinpoint the exact molecular pathways that are broken in the factory.
And these specific mutations can predict prognosis too.
Absolutely. Some mutations, like in spliceosine genes such as SF3B1, are associated with more favorable outcomes, maybe slower progression. Others, like mutations in TP53, EZH2, RUNX1, or ASXL1, consistently predict a poorer outcome and higher risk of transforming to leukemia. The pattern of mutations also tells a story. Early driver mutations might be present even with relatively normal blood counts, creating a clone that's susceptible, and then later mutations push it towards malignancy. Deep sequencing shows this clonal evolution happening over time.
So it's like a stepwise accumulation of genetic hits. Do the gene mutations and the chromosome abnormalities interact?
Definitely. They're not independent. For example, TP53 mutations often go along with complex multiple chromosome abnormalities. TET2 mutations often occur with normal chromosomes, and it's important to realize the abnormal clone might be bigger than it looks morphologically. Even normal-appearing cells can sometimes carry the underlying mutation. It's this accumulation of hits affecting tumor suppressors, oncogenes, epigenetic regulators like methylation, RNA splicing that drives the disease phenotype, the cytopenias, and the leukemia risk.
Are there specific MDS subtypes where the mechanism is particularly well understood, or still big mysteries?
The 5q syndrome is a good example where we have some clarity. The deletion leads to loss of one copy of a ribosomal protein gene, RPS14, causing problems with ribosome function, which seems to particularly affect red cell production, mimicking that congenital red cell aplasia. Also, the fact that lower-risk MDS can respond to immunosuppression suggests an immune component is important, at least in some subtypes. But yes, big mysteries remain. We don't fully understand the role of the immune system, the bone marrow microenvironment or niche, how the mutant cells actually cause the marrow failure. Lots of active research there.
Okay, let's turn to the clinical side. How does MDS typically present? What symptoms bring patients in? Or is it often found by chance?
Anemia symptoms usually dominate early on: fatigue, weakness, shortness of breath, pallor. But remarkably, maybe half of patients are actually asymptomatic when diagnosed. It just gets picked up on a routine blood test showing low counts.
What specific things should doctors ask about in the history? Any key exposures or family links?
Definitely ask about prior chemo or radiation. Fever and weight loss are less typical for MDS itself, more suggestive of a myeloproliferative process. In kids, MDS is rare and often points to an underlying genetic condition like Down syndrome predisposition. And family history is crucial: any hereditary sideroblastic anemia, Fanconi, telomeropathy signs like early graying or fibrosis. Gated 2 mutations, monomax syndrome, have links to specific infections and immune cell deficiencies. RUNX1 mutations also run in families, causing high MDS leukemia risk, often starting with just low platelets. Always ask, as these constitutional issues can show up in adulthood.
What about the physical exam? What signs might you find?
Mainly signs of anemia, the pallor. About 20% might have an enlarged splenomegaly, which is less common in aplastic anemia. Occasionally, specific skin lesions like Sweet syndrome, autoimmune conditions can coexist, and in younger patients, look hard for the subtle physical anomalies hinting at an inherited syndrome: short stature, thumb issues, Fanconi, funny nails, telomeropathy, warts, GAT.
Moving to the lab tests. What are the characteristic findings in the blood? How do the cells look wrong?
Anemia is almost always there, often with macrocytosis, large red cells. Platelets can be low, but also often look large and abnormal, lacking granules. They might not function well, causing bleeding, even if the count isn't desperately low. Neutrophils can look abnormal too: hypogranulated, weirdly segmented nuclei, like Pelger-Huet anomaly, maybe Dula bodies. These dysplastic features suggest they aren't working properly. You might see some circulating myeloblasts. The number is important for classification and prognosis. Total white count is usually normal or low, except in CMML, where monocytes are high. You can also find PNH clones sometimes. And genetic testing for those constitutional syndromes is key if suspected.
And the bone marrow exam in MDS.
Yeah.
How does it differ from aplasia, and what specific dysplastic features are you looking for?
Unlike aplasia's empty marrow, MDS marrow is usually normal or even hypercellular packed, but with faulty cells. Though about 20% can be hypocellular, causing confusion, there's no single defining feature, but you look for dysplasia in one or more cell lines. In red cell precursors, erythroid, abnormal nuclei, maybe ringed sideroblasts, iron-laden mitochondria. In granulocyte precursors, hypogranulation, abnormal segmentation, megakaryocytes, often reduced numbers or small with weird nuclei, pond ball forms. Increased myeloblasts are a key finding, and their percentage is critical for prognosis. Flow cytometry can help quantify blasts and detect abnormal maturation patterns. Cytogenetics looks for those characteristic chromosome changes.
What's on the differential diagnosis list? What else needs to be ruled out before landing on MDS?
First, rule out reversible causes of cytopenias and dysplasia. Vitamin B12 or folate deficiency, check levels. Maybe a trial of vitamin B6 if ringed sideroblasts are seen. Copper deficiency can also mimic MDS. Acute viral infections, drug reactions, toxins can cause transient dysplasia. Then the harder distinctions, hypocellular MDS versus aplastic anemia, genomics helps, and refractory anemia with excess blasts versus acute leukemia. The WHO uses that 20% blast cutoff in the marrow to separate them. And always consider underlying inherited predisposition syndromes, especially in younger patients.
Once MDS is diagnosed, how do you determine the prognosis? You mentioned it's highly variable.
Yes, extremely variable. Median survival can be years for low-risk types like 5q or sideroblastic anemia, but only months for high-risk forms with excess blasts or bad cytogenetics like monocyte 7. Predicting this is critical for treatment planning. The main tool we use now is a revised International Prognostic Scoring System, the IPSSR.
Can you walk us through the IPSSR? What factors does it include? Sounds complex but powerful.
It is comprehensive. It refines the older IPSS significantly. Key components include marrowblast percentage, categorized more finely now, the specific cytogenetic abnormalities, grouped into 5 risk categories based on prognosis, things like MYDOC-Y or del5q, are good, complex or chromosome 7 abnormalities are poor, and the depth of the cytopenias, how low the hemoglobin, platelets, and neutrophils actually are. It also formally incorporates other factors like patient age, performance status, serum ferritin, LDH, and beta-2 microglobulin. Combining all these gives a score that places patients into one of 5 risk categories, very low to very high, providing much better predictions of survival and risk of transforming to AML.
So even patients classified as lower risk by IPSSR can still have significant problems. It's not necessarily a benign condition.
That's a really important point. Even lower risk MDS carries significant morbidity and mortality. Patients suffer from complications of low counts, need transfusions, have reduced quality of life. And prognosis isn't static. It can change over time as the disease evolves genetically. While leukemia progression is a major fear, most MDS patients actually die from complications of the cytopenias, infection, bleeding, or from unrelated age-related diseases.
What signs indicate the prognosis is worsening, that the disease is becoming more aggressive?
Things like a rapid drop in blood counts, acquiring new or more complex chromosome abnormalities on repeat testing, an increasing percentage of blasts in the marrow or development of marrow fibrosis. These are all bad signs. And therapy-related MDS generally has a very poor prognosis, often progressing quickly to AML.
Treatment for MDS used to be just supportive care, but you mentioned newer therapies. What are the main strategies now?
Yes, treatment has evolved significantly. While historically unsatisfactory, we now have drugs that can improve counts, delay leukemia, and sometimes improve survival. But choosing the right approach is complex, requires specialist expertise because
Cure for MDS currently.
hematopoietic stem cell transplantation, HSCT, remains the only potentially curative option. Survival rates are maybe 50% at 3 years in selected groups, and improving. Unrelated donor outcomes are getting closer to sibling donor outcomes. Even patients into their 50s or 60s can be transplanted successfully sometimes,
But there's that transplant conundrum.
Exactly. The patients who most need a cure based on their high-risk disease, bad IPSSR score, poor cytogenetics, are also the ones most likely to have complications from the transplant itself or to relapse afterwards. Low-risk patients tolerate transplant better, but they might live well for years with less aggressive therapies, making the upfront risks of transplant harder to justify. So in reality, only a relatively small fraction of MDS patients actually undergo transplant.
What about standard cytotoxic chemotherapy, like used in AML? Does that work well in MDS?
Generally, no. MDS tends to be quite resistant to standard chemo. Plus, these drugs are very toxic, especially in the typically older MDS population, leading to high rates of complications and death. Even if remission is achieved, it's usually short-lived. So chemo has a very limited role.
So if chemo isn't great, what about those epigenetic modulators or hypomethylating agents? Sounds like they try to fix the cell's programming.
That's where a major advance occurred. These drugs, like azacitidine and decitabine, are thought to work partly by reversing abnormal DNA methylation chemical tags that can wrongly silence important genes needed for normal blood cell differentiation. By removing these tags, they might allow the MDS cells to mature more normally, improving blood counts.
How effective are azacitidine and decitabine?
Azacitidine was the first drug shown to improve survival compared to supportive care in higher-risk MDS. It improves counts in maybe 50% of patients. Decitabine has similar response rates. Both are given cyclically, often for many months. The main side effect is myelosuppression, potentially worsening counts initially. They are widely used, especially for higher-risk patients not eligible for transplants, but also increasingly in lower-risk patients. However, response isn't universal, and most patients eventually stop responding.
What about lenalidomide? You mentioned it's particularly good for the 5q subtype.
Yes. Lenalidomide, related to thalidomide, is remarkably effective for MDS patients with that specific isolated deletion of chromosome 5q. It can lead to transfusion independence and normalization of counts, sometimes even clearing the cytogenetic abnormality in a high proportion of those patients. Its exact mechanism is complex. It's taken orally. Main toxicities are myelosuppression and risk of blood clots, TBTP.
Can immunosuppression, like used in aplastic anemia, also work for some MDS patients?
Yes, for a subset. Younger patients, 60, with lower risk MDS, especially if their marrow is hypercellular, might respond to immunosuppression with ATG and cyclosporine. Response rates are maybe around 50% in selected groups, suggesting an immune component in their disease.
And hematopoietic growth factors like EPO or GCSF, any role in MDS?
They can help improve counts, but usually work best in patients with less severe cytopenias to begin with. EPO, sometimes with GCSF, can raise hemoglobin, particularly in patients with lower endogenous EPO levels and modest transfusion needs. It might even improve survival slightly. GCSF alone doesn't improve survival. Thrombopoietin mimetics can raise platelet counts, seemingly without increasing leukemia risk.
What's new on the horizon? Any exciting drugs in development?
Yes, several promising agents. Luspatercept is already FDA approved for anemia and MDS, especially with ring sideroblast. It targets a pathway suppressing red cell production, TGF-beta. Others in trials include inhibitors targeting hypoxia pathways, mutated spliceosome genes like SF3B1, drugs aiming to restore function of the p53 tumor suppressor, and venetoclax, which promotes cancer cell death. Lots of targeted approaches being explored.
And finally, supportive care for MDS. Still crucial.
Absolutely essential. Same principles as aplastic anemia, managing infections, bleeding risk. And crucially, for patients needing long-term red cell transfusions, iron chelation is vital to prevent organ damage from iron overload, secondary hemochromatosis. It's a marathon, not a sprint for many MDS patients.
Okay, our last scenario of factory breakdown, myelophasic anemias. This sounds like the factory isn't just failing or disordered, but actually being infiltrated or replaced by something else.
That's a perfect way to think about it. Myelophasic anemias are characterized by fibrosis scarring of the bone marrow space. This is usually accompanied by a very specific blood smear finding called leukoerythroblastosis.
Leukoerythroblastosis, what does that mean?
It means you see immature white blood cells, leuko, and nucleated red blood cells, erythroblasts, circulating in the peripheral blood where they shouldn't normally be. It's a sign that the normal marrow structure is totally disrupted, and hematopoiesis might be happening outside the marrow too.
Is this fibrosis usually a primary marrow disease, or is it secondary to something else?
It can be a condition called primary myelofibrosis, which is a type of chronic myeloproliferative neoplasm. But often what we encounter clinically is secondary myelophysis, where the fibrosis is reactive. It's the marrow's response to being invaded or chronically inflamed by something else.
What kinds of things typically invade or inflame the marrow to cause this secondary fibrosis?
Most commonly, it's invading tumor cells. Metastatic cancers, especially from breast, lung, or prostate cancer or neuroblastoma, often spread to the bone and trigger fibrosis. Chronic infections can also do it, particularly mycobacteria like TB or fungi, sometimes HIV. Systemic inflammatory diseases like sarcoidosis can be a cause too. And rarely, metabolic diseases like Gaucher disease, lipid storage, or congenital osteopetrosis, abnormally bent bones, can obliterate the marrow space.
Can treatments cause it too?
Yes, it can be a late effect of radiation therapy or treatment with certain chemo drugs. It can also be seen in association with other blood cancers like CML, multiple myeloma, lymphoma, or hairy cell leukemia, where the malignant cells infiltrate the marrow. Usually, though, the underlying cancer or infection causing secondary myelofibrosis is fairly obvious clinically.
So physiologically, what's happening? How does this infiltration lead to anemia and those weird blood findings?
There are three key features. One is the fibrosis itself. Fibroblasts proliferate and lay down scar tissue, crowding out the normal blood-forming cells. 2 is extramedullary hematopoiesis, also called myeloid metaplasia. Because the marrow environment is hostile, blood production shifts to other organs, typically the spleen and liver, which often become enlarged. These satellite factories aren't as efficient. And 3 is ineffective erythropoiesis. The red cells that are produced either in the fibrotic marrow or the extramedullary sites are often abnormal and don't survive long.
Why does the marrow get fibrotic? What triggers the scarring?
The exact trigger isn't fully known, but it likely involves abnormal production of growth factors within the marrow microenvironment. Factors like platelet-derived growth factor, PDGF, and transforming growth factor beta, TGFF, are strongly implicated as they stimulate fibroblasts. Dysregulation of other signals might cause hematopoietic cells to set up shop outside the marrow and disrupt the normal balance within it.
What are the key clinical and lab features? How is it typically diagnosed?
Anemia is the main clinical problem, usually normocytic, normochromic. The big clue is the leukoerythroblastic blood smear, seeing nucleated red cells and immature white cells, myelocytes, promyocytes, maybe even blasts, circulating together. Red cell shapes are often bizarre. Teardrop cells are classic, along with other distortions, reflecting their traumatic journey out of the fibrotic marrow or production in weird places. White count might be high, low, or normal, but the presence of immature forms is key. Platelets can be low, normal, or high, and often look giant and abnormal.
Any clues during the marrow biopsy procedure itself?
Yes, a classic sign is the dry tap. Because the marrow is so fibrotic, you often can't aspirate any liquid marrow. This finding, in the right clinical context with the leukoerythroblastic smear, is highly suggestive even before the biopsy core is processed, which requires decalcification.
And what determines the patient's course and treatment? Is it all about the underlying cause?
Entirely. The prognosis and treatment of secondary myelofibrosis depend completely on the underlying cause, usually metastatic cancer or another advanced hematologic malignancy. The main focus is treating that primary condition. It's vital to rule out treatable causes like TB or fungal infections. Supportive care, especially blood transfusions, can help manage the anemia symptoms, but the ultimate outcome hinges on controlling the disease that's infiltrating the marrow.
Wow. Okay. We have covered an immense amount of ground today. From the immediate shock of acute post-haemorrhagic anemia right through the really deep complexities of the bone marrow failure syndromes. I mean, the subtle differences between aplastic anemia and MDS, the specific gene mutations, the sophisticated treatments. It feels like we've really built a professional level understanding of how this vital factory can go wrong and what medicine can do about it.
Absolutely. We started with that sudden leak, APHA, and the body's rapid response. Then we peeled back the layers on the chronic breakdowns of aplastic anemia's empty factory, PRCA's specific gap, the disordered production and leukemia risk in MDS, and finally, the infiltrated factory in myelodysplasia. We've dug into the genetics, the immunology, the cellular problems. You really should feel like you've mastered the core concepts from Chapter 102 now, understanding how the blueprint, the defenses, and the production lines can all fail.
It's truly incredible how much we've learned and how treatments have advanced. Which leads me to a final thought for you, our listener, to ponder. Given this incredible complexity, we've discussed the interplay of genes, immunity, environment, and marrow failure. What could be the next big leap? Could there be diagnostics or therapies that offer more universal solutions, going beyond the specific targeted approaches we have now? And how might our growing understanding of those very early genetic shifts, that clonal hematopoiesis that happens before overt disease, maybe reshape how we think about preemptive or ultra-early intervention? Could we potentially stop the factory from breaking down before it even starts to show signs of failure? Something to think about.